record. Good morning, good afternoon, good evening to you watching these in the comfort of your home and in the comfort of your time. I am Goodell Raiko Citizen and I am assigned to discuss about and delineate specific phobias, agoraphobias, and social anxiety disorder. A phobia is an irrational fear of many objects and situations that are likely to cause harm. The DSM-5 divide phobias into specific phobias, such as or focus on the objects and animals, example snakes, places, example heights, and agoraphobia, which is generalized fear of situations in which people might not be able to escape or get help when needed. Specific phobias. Specific phobias are unreasonable or irrational fear of specific objects or situation. The DSM-5 categorize them into animal type, natural, environmental type, situational type, blood injection, injury type, and others. Animal type. Animal type phobias focus on specific animals or insects such as dogs, cats, snakes, or spiders. Snakes and spiders are the most common objects of animal phobias, probably because it has been adaptive over evolutionary history to fear these objects. While most people who come across the feared animal or insects will startle or move away quickly, they would not be diagnosed with the phobia because they do not live in terror of encountering a snake or a spider or organize their lives around avoiding them. Then we have natural environment type. Natural environment type phobias focus on events or situations in natural environments such as storms, heights, or water. Mild to moderate fear of these natural events or situations are extremely common and are adaptive in that they help us avoid danger. The diagnosis of phobia is warranted only when people recognize their lives to avoid feared situations or have severe anxiety attack when confronted with them. Then the situational type. Situational type phobia usually involve fears of public transportations, tunnels, bridges, elevators, flying, or driving. Claustrophobias or fear of enclosed spaces is most common situation phobia. John Maiden is one of the prominent of these phobia. He's a former and coach and former sports announcer who traveled 60 miles a year in his personal bus around the United States because so afraid of flying. While these three type, animal type, natural environment type, and situational type have experienced increase in heart rate, blood pressures, and other flight or fight responses when confronted with their fear objects and situations, the blood injection injury type, however, experience significant drops in heart rate and blood pressures and are likely to faint. It is more a nature than a nurture. Blood injection injury types are diagnosed in people who fear seeing blood or an injury. The specific phobias, when people with these phobias encounter their feared objects or situations, their anxiety is immediate and intense, sometimes producing a panic attack. They also become anxious over the possibility of encountering the objects or situations when will go to the great length to avoid them. Then we have agoraphobia. Agoraphobia or fear of the market. People with agoraphobia fear the places where they might have trouble escaping or getting help if they need become anxious. These often include fear of public transportations, being on a bus, train, plane, or boat, open spaces such as parking lot, being on a shops or theaters, crowded places, or being alone anywhere outside the home. People with agoraphobia also often fear that they will embarrass themselves if the others notice their symptoms or their efforts to escape during an attack. Actually, people rarely tell when the person is anxious. Then panic, about 50% of the people with agoraphobia has history of panic attack before the development of the agoraphobia. The remaining people with agoraphobia typically have a history of another anxiety disorder, a somatic symptoms disorder, or depression. Agoraphobia most often begin when people have 20s and is more common to women than men. People with agoraphobia often reach the point where they will not leave their house alone. Sometimes they are able to venture out with a close family member who makes them feel safe. However, family and friends will not be willing to chaperone them anywhere they go. Then we have the theories of phobias. The phobias have been the battleground among various psychological approaches to abnormality. Freud argued that phobias result when unconscious anxiety is displaced onto the neutral or symbolic objects. That is, people become phobic of objects or situations because they have displaced their anxiety over other issues onto them. But in general, psychodynamic therapy is not highly effective for treating phobias, suggesting that insight into unconscious anxiety is not what is needed in their treatment. There comes the behaviorism theories. In contrast to psychodynamic theories, behavioral theories have been very successful in explaining phobias. According to Maurer, two-factor theory suggests that classical conditioning leads to the fear of objects or phobic objects, and operant conditioning helps maintain it. In classical conditioning, a previous neutral object is paired with an object that um, elicits the unconditioned response until the previously neutral object elicits the same response, or now called a conditioned response. It is true to Little Albert's phobia experiment, where the pairing of bang bars, the unconditioned stimulus, which naturally leads to startle responses, the unconditioned response, and the white rats, the conditioned stimulus eventually led to the white rat producing the same startled response, now referred to the conditioned response. Most people who develop phobia, however, try to avoid being exposed to their feared object, thus avoiding that could extinguish the phobia if they are suddenly confronted with their feared objects. They experience extreme anxiety and run away as quickly as possible. Running away reduces their anxiety, thus their avoidance of the feared objects is reinforced by reduction of their anxiety, and operant conditioning process known as the negative reinforced thereafter they avoid the feared objects. Some theories argue that phobias can develop through observational learning as well as through direct classical conditioning. Many phobic objects appears to be things whose avoidance over evolutionary history has been advantageous for human. Our distant ancestors have many or had many nasty encounters with insects, snakes, heights, loud noises, and strangers. Those who quickly learned to fear and avoid these objects or events were more likely to cause us harm today, to cause were eventually more likely to revive and bear upspring. Thus, evolutionary have selected for rapid conditions or fear to certain objects or situations. Although these are less likely to cause harm today, we carry the vestiges of our evolutionary history and are biologically prepared to learn certain associations quickly. This theory is known as the prepared conditioning. The behavioral theories seem to produce accompanying explanations for phobias, particularly when we add up the principles of observational learning and prepared classical conditioning. It has also led to effective therapies. Then we have biological theories. The first degree relatives, that is the parents, children, and siblings of people with phobias, are 3 to 4 times more likely to have a phobia than those without. Twin studies suggest that this is due at least in part of genetics. Some studies suggest the situational and animal phobias are associated with similar genes, while other studies suggest that general tendency towards behavior is not isolated to one type of phobia. Then we have treatment for phobias. A number of behavioral techniques can treat phobias. Some therapies include cognitive techniques and medications. We have behavioral treatments. Behavioral therapy for phobia use exposure to extinguish the person's fear of the object or situations. These therapy cure the majority of the phobias. Some studies suggest that just one session of the behavioral therapy can lead to major reductions in phobia behaviors and anxiety. Three basic components of behavioral therapy for phobias are the systematic desensitization, modeling, and flooding. First, we have systematic desensitization. In systematic desensitization, clients formulate lists of situations or objects that they feared, ranked from most to least feared. Um, they learn relaxation techniques and begin to expose themselves to the items of their hierarchy of fears, beginning with the least feared. The therapist will coach his or him to use relaxation techniques to replace his or her anxiety with the calm reactions. Gradually, the client and the therapist will move through the entire list until the client is able to conquer the phobia without fearing overwhelming anxiety. By the way, in blood injection injury, phobia requires different approach because people with this type of phobia experience severe decrease in heart rate and blood pressure. Thus, therapy teaches them to tense the muscles in their arms and legs and chest until they feel the warmth of the blood rising in their faces. The applied tension techniques, as it's called, increases the blood pressure and heart rate and can keep people with this type of phobia from fainting when confronted with the feared objects. The systematic desensitization can help extinguish fear of blood injury or injections. And then we have the modeling. Modeling techniques are often adopted in conjunctions with a systematic desensitization. The therapist may perform as a model its behavior of the client's hierarchy of fears before asking the clients to perform it. Through observational learning, the client associates these observations with a calm response in the therapist, which reduces anxiety about engaging the behaviors. Modeling is effective as systematic desensitization and reducing phobias. Then finally, we have the flooding. Flooding intensely exposes a client to feared object until anxiety is extinguished. Still, relaxation techniques typically will prepared to reduce client's fear. In flooding treatment, in a flooding treatment, a person with claustrophobia might lock himself in a closet for several hours. The flooding is as effective as systematic desensitization or modeling and often works more quickly. However, it is more difficult to get clients to agree with this type of treatment because it is frightening to contemplate. Then we have biological treatments. Some people use benzodiazepine to reduce their anxiety when forced to confront their phobic objects. For example, they use Valium before flying and giving presentation. These drugs produce temporary relief, but the phobia remains. In contrast, the behavioral techniques can cure most phobia in a few hours. For now, it appears that the age-old advice to confront your fear through behavioral therapy is the best strategy. Then we have social anxiety disorder. Most of us don't like to be embarrassed in front of others or rejected by other people. And the table as shown, one of the most common social fear is public speaking. Nearly half of the students identify themselves as shy and say they get nervous meeting new people, encountering unfamiliar situations. People with social anxiety disorder become so anxious in social situations and are so afraid becoming rejected, judged, and humiliated in public that they are preoccupied with worries about such event to the point that their life may become focused on avoiding social encounters. In In social situations, people with social anxiety disorder may tremble or perspire, feel confused or dizzy, have a heart palpitations, and eventually have a full panic attacks. People with social anxiety disorder may avoid eating or drinking in public for fear that they will make noises when they eat their food or otherwise embarrass themselves. They may avoid writing in public, afraid that others will see their hands tremble. Men with social anxiety disorder often avoid urinating in public bathrooms. Um, Women are somewhat more likely to men to develop this disorder. One study found that women with social anxiety disorder have more severe social fears than men, particularly with regard to performance situations. Social anxiety disorder tends to develop in either the early preschool year or adolescence, when many people become self-conscious and concerned about others' opinion of them. Social anxiety disorder often co-occur with mood disorders and other anxiety disorders. And once it's developed, social anxiety tends to be chronic if left untreated. But most people do not seek treatment. In Japan, the term Taijenko Fushu describe an intense fear of interpersonal relationship. It is characterized by shame about a persistent fear of causing other offense, embarrassment, or even harm through one's personal inadequacies. This concern is in line with the emphasis in Japan's on deference to others. Then we have the theories of social anxiety disorder. Social anxiety, or more generally shyness, runs in families and twins. Studies suggest it has genetic basis. Genetic factors do not appear to lead specifically to anxiety about social situation, however, but rather to more general tendency towards the anxiety disorder. Then we have cognitive perspective. Cognitive perspectives on social anxiety disorder have dominated in psychological theories. According to this perspective, people with social anxiety disorder have excessively high standards for their personal performances. They also focus on negative aspects of social interactions and eventually evaluate their own behavior harshly. After a social interaction, they ruminate excessively about their performance and the other person's reactions. Then we have treatment for social anxiety disorder. The selective serotonin reuptake inhibitors, or SSRIs, and the serotonin norepinephrine reuptake inhibitors, or SNRI, have been shown to be efficacious in reducing symptoms of social anxiety. Symptoms tend to return when individuals stop taking these medications, however. That's why the cognitive behavioral therapy comes in that seems particularly useful in treating social anxiety. The behavioral component of the therapy involve exposing clients to social situations that make them anxious, um, starting with the least anxiety-producing situations and working up to more anxiety-producing situations. The therapies may be role play, the situation with the clients, accompanying clients in social situations, to coach them as many engaged in social encounters, and assign clients to whom work to carry the experiments in which the attempts at social interactions they believe they can tolerate. The cognitive component of the therapy involve identifying negative cognitions of clients have for their own about social situations and teaching them how to dispute these cognitions. CBT for social anxiety can administered in group settings in which group member from an audience of one another providing exposure to various situations each member fear. Individual can practice their fear behavior in front of other while the therapist coaches them in the use of relaxation techniques to calm their anxiety. The group can also help the client challenge any negative catastrophizing thoughts about his or her behavior. A number of meta-analyses have found that the cognitive behavioral therapy is effective treatment for social anxiety disorder. It's just as effective an antidepressant in reducing or reducing symptoms over the course of therapy. It is much more effective in preventing relapse following therapy. The CBT is equally effective whether administered individually or in group. Finally, we have the mindful based intervention. This treatment also can prove helpful for people with social anxiety disorder. This intervention teach individuals to be less judgmental about their own thoughts and reactions and more focused on and relaxed in the present moment. So again, I am Gabriel Raico Citizen. Breathe and keep inspiring.